Yeah, so this is something that they ask questions on in your finals, but you don't really get much teaching on. So disclaimer, I'm a med student. This might be right, might be wrong. I've tried my hardest to make sure it's right and it matches what past med and such will tell you. But usual caveats, I'm not an ophthalmologist. So we'll start with a case. We've got a 3-year-old female. Her name's Maggie. She's come in with a swollen eye, erythema around the right eye, and she's struggling to open her eye. You ask for a history, nothing exciting, but mum says, oh, she had a cold a couple of days ago, and when she had the cold, she was saying her face hurts. You examine her. She's systemically unwell. You struggle to check her visual acuities. That's what VA stands for, partly because she's a 3-year-old girl. Checking visual acuities is really difficult anyway. She's got conjunctival injection, so that's when you've got sort of red blood vessels throughout your eyes, and she's got a degree of ptosis of the eye. Anyone got any ideas what the differential could be? Drop it. Put it in the chat. Anyone?
This orbital cellulitis.
It is indeed. This is what I'm hinting at. Any other diagnosis? Doesn't have to be ophthalmology based.
Periorbital cellulitis.
Yep. So that's what this case is. Anything else? So I'll give you a differential. So this is the picture of her condition. So it's quite a wide differential. And as you said, orbital cellulitis is probably the most important one to rule out. Preseptal cellulitis, so we'll go through the difference between the two. You've got stuff like STI, chalazion, allergic conjunctivitis. The one also not to miss out is anaphylaxis. And you could obviously get nephrotic syndrome, causes swelling of the eyes. Anyone know why nephrotic syndrome causes swelling of the eyes and most other forms of edema don't? Any idea? It's generally because people with nephrotic syndromes can lie flat, so gravity will allow the fluid to drain towards the head, whereas people with like heart failure tend to get quite breathless if you lie them flat. And blepharitis really doesn't cause eyelid swelling on its own usually, but it can cause stuff like styes and chalazion, which we'll talk about later. So don't get daunted by the anatomy here. I don't really need to talk through much apart from point out this bit here. Can you all see my cursor? Can anyone see my cursor?
Yeah, it's moving.
Brilliant. So that's the orbital septum. So any cellulitis in front of the orbital septum is called preseptal cellulitis or preorbital cellulitis, and any cellulitis posterior to that septum is called orbital cellulitis. So we'll talk about preseptal cellulitis first. As I said, it's infection of the sophtheria anterior to the orbital septum. It's mostly occurring in children. About 80% of cases are in the pediatric population. Other people who might get it are people with immunosuppressed. And so they tend to present with erythema around the eye, eyelid swelling. It tends not to affect vision, but you might find that you get some blurry vision with it, and you get conjunctival injections. So causative organisms, staph, strep, Haemophilus influenza, although now we're vaccinating against it, then we see it a bit less often. So diagnosis, a lot of websites seem to be suggesting that you could diagnose it clinically if you're happy it's not orbital cellulitis, but if there's any doubt, then you'll need to CT it. So management, in this case, you'd give like a systemic antibiotic, so something like amoxicillin. So orbital cellulitis, this is bad. It can be sight-threatening and it can be life-threatening, so don't miss this. Again, pediatric population. So they're the group that tend to get this most commonly, and it's infection posterior to the orbital septum. So you get the same sort of presentation, your preseptal symptoms of, erythema and swelling, but you also have some red flag signs. So proptosis, eyelid eye protruding forward, chemosis, swollen conjunctival, ophthalmoplegia, relative afferent pupillary defect. These kids will be systemically unwell, might have painful eye movement, altered visual acuity, or blurring. So this is from a poster produced by the East Midlands Emergency Medicine Network. So if you type in orbital cellulitis, East Midlands, onto Google Images, it will come up with the full poster for it. So the typical history is that it results from an infection tracking up from the ethmoid sinuses. So it's quite often the case that these kids will have a upper respiratory tract infection antecedent to this occurring. And as you can see, the complications are really quite nasty. So you can end up blind due to optic nerve compression, osteomyelitis, meningitis, cerebral abscess. So if you're in any doubt, these kids need to be admitted. They need an urgent ophthalmology referral, and they'll need to do a CT, MRI, blood cultures, IV antibiotics. And if there's pus around the eye, then that may require surgical drainage. So this is certainly something worth not missing. So from quite a major diagnosis to quite a small diagnosis, a STI. So this is literally an infection of the sebaceous glands of the eyelashes or the meibomium gland. We'll talk about what the meibomium gland does in a second, and it's normally a staph infection. So you have a tender red lump and the swelling of the eyelid. I suspect a lot of you will have had one at some point. And the management's quite simple. So it's just a hot compress and analgesia. And then if it's sort of persistent and not going away, / if there's conjunctivitis, then you might want to give some chloramphenicol, which is an antibiotic that you tend to give an eye drop preparation, and you can remove the affected eyelash just to facilitate drainage. Any questions so far? Dream. Okay, so chalazion. So that's a blocked meibomium gland. So what the meibomium gland does is it secretes phospholipid to lubricate the eyelid. So typically what happens is these glands will get blocked and you get non-tender swelling of the eyelid. So it's not an infection, but because you've got the phospholipids milling around, you get like a granulomatous inflammation. And again, management, hot compress, analgesia, and then if it just keeps giving problems, then sometimes you can surgically drain it. So you just lift the eyelid up and then pierce the posterior part of the eyelid to drain out. But normally that's not necessary. It's a self-limiting problem. So blepharitis, I definitely remember a few past med questions with this coming up. So it's literally an inflammation of the eyelid margins. And as I said, often doesn't cause swelling on its own, but can lead to styes or chalazion. These patients will present complaining of gritty, itchy, dry sensation in the eyes, and you'll notice crusty flakes, which you can see in this picture here. Management's just a case of cleaning the eyelid with cotton wool and sterile water. And if it's really sort of dry and gritty, you can give some lubricating eye drops to help. But it normally resolves quite quickly. So going back, should we go back to the first case? So as you guys correctly said, it's orbital cellulitis. So this is the hints for that is that she had a cold and saying her face hurt. So this is trying to hint that her ethmoid sinus she had a degree of sinusitis, and she's systemically unwell, and proptosis. So they're the two red flags that would suggest that she's got orbital cellulitis over preseptal cellulitis. Anyone want to just go through the management of this kid? Not all at once. Okay, so yeah, go ahead.
I was going to say, if it's an infection, do you just want to give antibiotics and supportive treatment?
Yeah, so for orbital cellulitis, definitely needs antibiotics. She's going to need admission, and she's going to need an urgent ophthalmology review with a CT scan as well. because they might need to do a surgical drainage of around the orbit. So cool, that's us all done in terms of eyelid swelling. So next case, Todd, 25-year-old male, 2-day history of red eyes, feels itchy, not painful, wakes up with eyelids stuck together. On examination, conjunctival injection and a purulent discharge. That's probably not how you pronounce it, but hey ho. Anyone want to suggest a differential? If you drop it, I can have a look at the comments. So just put it in the comments if you don't fancy saying it. What do you think he's got? I'm feeling
Bacterial
lonely here.
conjunctivitis.
Yes, yeah. Brilliant. Anything else that it could be? Keratitis? Yeah, okay. We'll talk about those in a bit later. So the main thing is that it's not painful. This is quite important. So differential for an acute red eye that's painless is generally either conjunctivitis, episcleritis, subconjunctival hemorrhage, and that's really it. Obviously, a lot of the pathologies that we'll talk about for the painful side could probably come here if they're on the milder or beginning part of their disease process. So conjunctivitis. So I'm sure you already know this, but the conjunctiva also loops around to the posterior surface of the eyelid, so it doesn't just affect the actual bit over the orbit. 3 types that we'll talk about: viral, bacterial, and allergic. So this is gold in terms of exams. They tend to love chatting about this. So bacterial is stereotypically bilateral. Remember, bilateral, B, bacterial. And yeah, that's just purely because it's so infectious. So people will rub their eyes and then rub the other one. You have a purulent discharge. You can get something called a papillary conjunctival reaction. So if you peel down the eyelids, you'll get them to pull down their eyelids, you'll just see little bumps inside the eyelids. And the sort of typical exam question way of phrasing it is they'll often wake up in the morning with their eyes stuck together. So management wise, it is generally self-limiting. So there's lots of advice in terms of don't share towels, because obviously it's quite infectious. Don't wear contact lenses, and just clean your eyes with cotton wool. But you're also going to need to consider antibiotics. So chloramphenicol may be indicated. The NICE guidelines seem to indicate that a good strategy to use is to give them a delayed prescription. So same as you do with lots of other conditions, and think if it could be an STI-based infection, so chlamydia or gonococcal. So viral, it's stereotypically unilateral. This rule isn't hard and fast, but for exam questions, it's pretty helpful. Clear discharge as opposed to a purulent. I can never say it. It's changing every time I say it. Periarticular lymph node enlargement, and they might have other symptoms of viral infection. So they might have an urtia or something like that. Same management, except this time you wouldn't give antibiotics because it's kind of a bit pointless. And then allergic conjunctivitis. So I suspect a few of you have hay fever and have experienced swollen, watery, itchy eyes, and you get obviously all the other atopic symptoms, the nasal congestion, and the management is your hay fever management. Worth mentioning, if you've got swollen eyes and it's bilateral, just check it's not anaphylaxis, because it's probably worth not missing that one. Episcleritis. So the sclera, the white part of the eye, goes all the way around the orbit, and the episclera is the outermost area. So the typical clinical presentation is painless. It's segmental redness, so only a part of the eye, and you get watering of the eyes. So it's implicated with a load of different conditions. So you've got inflammatory and rheumatoid diseases, IBD, RA, I think SLE is also implicated as well. And there's a way to differentiate between scleritis and episcleritis. And the way you do that is give drops of phenylephrine. And what that will do is in episcleritis, it will cause the blood vessels to constrict, and it will then sort of slightly reduce the reddening. Whereas in scleritis, it can't get down that far. And then so when you give the phenylephrine, there'll be no change. Management is analgesia and cold compress. It's a self-limiting sort of condition, but it's always worth thinking about, okay, they've got episcleritis, why have they got it? So think about the underlying cause here. Finally, subconjunctival hemorrhage. So it's normally a blood vessel rupture following strenuous exertion. A couple of you probably will have had it at some point. So typical history is, they were sneezing a lot or coughing, or they were lifting a weight, and then they woke up and noticed that their eye was a bit red. But also think about, there are certain conditions that will increase your likelihood of getting it. So hypertension, if they've got a bleeding disorder or anticoagulation, then they're more likely to get subconjunctival hemorrhage. So if they're, say, on warfarin, it might be worth checking their INR. If they come in presenting with a subconjunctival hemorrhage, just check that it's not off. Self-resolving, you just leave it, gets better. Happy days. Okay, case number 3, Sherry, 50-year-old female. She comes in with a headache, vomiting, blurry vision in left eye, and red left eye as well. So on examination, 6-9, so that's just a way of representing visual acuities. I think we did a lab in year 2 that covered it, but if you can't remember what that means, it's worth reading up. And then on the left, it's 660 with pinhole, so the pinhole's there to correct for refractive error, and you can 660 is pretty naff. Tonometry, so that's just measuring the pressure. Below 21 is normal. So right eye 13, happy days. Left eye 46, not happy days. Left eye is hazy, and she's got an unreactive pupil. So anyone want to hazard a guess as to what condition she has? Drop it in the, close angle glaucoma. Habas has got it. Any other differentials? There's quite a long differential. I think Sarah's suggestion of keratitis earlier definitely is a good suggestion, and then we'll go through all the other conditions that it could be. So this is the differential for acute red eye when it's painful. Conjunctivitis, I suppose, also could be a bit painful, but it tends to be more itchy than painful. So closed angle glaucoma or acute angle glaucoma, that's definitely one that you cannot be missing. That's a sight-threatening emergency. Anterior uveitis, scleritis, corneal abrasion or ulceration, keratitis, foreign body, and traumatic or chemical injury. So we'll talk through glaucoma to start with. So let's go very, very brief recap of the eye anatomy. So this is the vitreous chamber in the posterior segment of the eye. So you've got your retina here, your optic nerve, your fovea. I know you've covered this. And then you've got your posterior chamber, which is between your ciliary body and your iris, and the anterior chamber. And rather confusingly, the posterior and the anterior chamber make up what's known as the anterior segment. So vitreous chamber has vitreous humor, the posterior segment has vitreous humor, and the anterior segment has aqueous humor. So the flow of aqueous humor is produced by the ciliary epithelium. So the ciliary epithelium has a couple of functions. It nourishes the lens and the suspensory ligaments, and it provides structure, but it also will produce aqueous humour that travels through the posterior chamber into the anterior chamber and then drains into the trabecular meshwork, which is sort of like a spongy region, then into Schlemm's canal, one of the coolest names in anatomy, and then it will eventually drain into the episcleral veins. So glaucoma is a problem with this flow that will result in raised intraocular pressures. So two types that we're going to talk about. There are a couple of others, but ain't nobody got time for that. So you can have open angle glaucoma. That tends to be a chronic condition, so we're not going to talk about that today, but definitely something that you need to know about. So in that, the flow of aqueous humour is fine up until you get to the trabecular meshwork. And what you find in open angle glaucoma is the trabecular meshwork, the flow of aqueous humour over time through the trabecular meshwork gets impaired, and then you end up with chronically raised pressures in the eyes. In contrast, acute angle closure glaucoma, as suggested by the name, is acute. It's very sudden in onset, and in this case, what happens is the iris is pushed forward, and it will shut off the flow of aqueous humour into the trabecular meshwork. Now, the most common time that this occurs is when the eye, you get dilation of the eye, because this iris will get shorter and it will get fatter, and then it will close off your angle. And once the angle's closed, the problem is that the aqueous humour will still be produced, so the pressure in this posterior chamber will build up and push the iris further forward even more. So this can be precipitated, so going from an area that is light into an area that is dark, where you get dilation of the eyes, can precipitate an acute angle closure. Also giving drugs that cause dilation of the pupil, so anything like tropicamide, which is the drug that the optometrist will give you when they want to check the back of your eyes. So if you're going to dilate someone's pupil, check they've not got acute angle closure glaucoma. And there are a lot of other drugs that cause pupil dilation as well. So as I've said, I've just explained the first point, but I've written it out as well because I'm generous. Risk factors. As you get older, your risk increases. That's pretty much the same for everything I can think of. Perhaps not pyloric stenosis, but most things. Females are greater risk. Family history is a huge risk factor, and there may be some variation among ethnicities. So, as I said, certain drugs can lead to an acute closure: tropicamide, amitriptyline, NORAD, or oxybutynin. This is a sight-threatening emergency, so this is not one to miss. Okay, busy slide, but the clinical presentation is pain. These people are in absolute agony. I remember the first time I saw one, I was working in an ophthalmology outpatients clinic as an 18-year-old, and this person was just being sick everywhere. They had headache, they wanted to be in a dark room. They will have blurred vision and significant, they will have blurred vision, and they'll also report halos around lights. When you examine them, you'll see a really red eye. You'll notice their visual acuities are awful. You'll also find that often their pupils fixed and dilated. They have a hazy cornea, and then when you do tonometry, which is just checking the pressure in the eyes, that will be raised. So tonometry works much the same way as kicking a tire. So you can kick a tire and work out how inflated it is. There's loads of different devices to check the pressure in the eye. The one that you'll probably be familiar with if you've gone to the opticians is the one that blows air into your eye. So that's what they're doing. They're just checking the pressure in the eyes. So management of this condition: analgesia is imperative. These guys are in agony, and an antiemetic. Get ophthalmology there as quickly as possible. And the actual treatment of the condition involves increasing the flow of the aqueous humour and then decreasing the production. So all the drugs that we give for glaucoma really just work via those two mechanisms. So pilocarpine causes constriction of the pupils. As I said, as the pupils dilate, the iris gets shorter and fatter and tends to block off the angle in closed angle glaucoma. So if you give pilocarpine, then you can find that the flow will improve. And acetazolamide, which is a carbonic anhydrase inhibitor. For those of you who have been at altitude, you might have taken it before. It ruins the taste of beer, but it also decreases the production of aqueous humor. So in acute angle closed glaucoma, you will give acetazolamide. You can then give a whole range of other drugs, so beta blockers, because the production of aqueous humor is beta adrenoceptor mediated, hyperosmotic agents. Brimidine is also a carbonic anhydrase inhibitor that you might give. But the two that you probably need to know about are pilocarpine and acetazolamide. Okay, the good thing about ophthalmology is they use lasers a lot, and that's quite cool. But one of the management strategies that you can do is something called a laser iridotomy, where you basically will burn a hole between the posterior chamber and the anterior chamber, and that will allow the flow of the aqueous humor, and then it will reopen the angle. So you can see it on the pupil as like a little black, in the iris, a little black dot, typically above the pupil. Okay, anterior uveitis. We're not far off having a break. I'm dying for a cup of tea. So anterior uveitis is inflammation of the uvea. So that's your iris, your ciliary body, and your choroid going all the way around, but it tends to be the anterior part. It's typically autoimmune, but can have other causes, and it can be acute or chronic. So has a lot of associations. Angstbond are reactive arthritis. So if you think about your mnemonic, can't see P or climb a tree, the can't see is the reactive arthritis side of things. And then IBD, and then chronic associations are your sarcoids, your TBs, your herpes. So clinical presentation, you will typically find that they report a dull aching pain, lacrimation, so very teary eye, photophobia, and then ciliary flush. So if you have a look, I think the diagram probably conveys it the best. These are both computer generated, to be fair, but you'll see that it's most red around the iris. Abnormally shaped pupil, so I'm not going to try and pronounce that word there, but it's basically you get adhesions, and so you get sort of irregular pulling of your irregular contraction and pulling, leading to a distorted pupil. You get painful eye movements, and then a hypopyon. So a hypopyon, I'll show you a picture later on, is basically inflammatory cells in the anterior chamber, and you get sort of like a line of it right at the bottom of the eye. So it's pus in the anterior chamber, basically. Management, you need urgent ophthalmology referral. You need visual acuities, slit lamp tonometry, probably steroids. A lot of the pain from uveitis comes from the pupil, the ciliary muscle contraction, and the pupil constriction. So if you dilate the pupil, you can reduce the pain quite a bit. And as is the case in a lot of ophthalmology, you can always shoot a laser at it. Okay, scleritis. So we talked about episcleritis. Scleritis is a lot worse. It's inflammation of the sclera. It has much the same associations as episcleritis. Wegener's, well, the disease formerly known as Wegener's, GPA, seems to, I think in our finals, came up a load of times. Yeah, just learn some of the associations. Severe pain, painful eye movements. So that's as a result of the fact that your muscles attach into the sclera. So every time you move, if there's inflammation, it's going to be quite painful. I'm just going to shut the window because I'm ready to die. Okay, You get abnormal pupil light reactions, you can get photophobia, so you can do it on examination, and we were talking about phenylephrine as a means of distinguishing between episcleritis and scleritis. And you can see in this patient, they've got the worst form of scleritis, which is known as necrotizing scleritis. And you can, in bad cases, it can sort of go all the way through and you can get all sorts of problems. So NSAIDs and steroids can be part of the treatment. This is going to be ophthalmology managed, and they will often require treatment of the underlying condition. Okay, keratitis. So as Sarah mentioned, this is one of the differentials. It's inflammation of the cornea. The one that you probably need to know about is herpes. So you can get painful red eye, vesicles around the eye. So I suppose in the same way that in Ramsay-Hunt syndrome, you get vesicles in the ear canal, in herpetic keratitis, you can get vesicles around the eye. You can get changes in visual acuity. And depending on what layer of the cornea that it affects, if it affects the stroma, you can get stromal keratitis, which can cause scarring. So slit lamp examination as per, fluorescein staining. So fluorescein is like a dye, and you will see a dendritic ulcer in herpetic keratitis. So you can see quite a nice example of it. And you'll need to do a viral swab as well. You can treat this with acyclovir, steroid drops, and if they've got stromal keratitis leading to scarring, then you need to do a corneal transplant sometimes. Where are we at? Okay, corneal abrasion. This comes up quite a bit. It's what it says on the tin. It's common causes, contact lenses. Contact lenses are quite nasty. They cause all sorts of problems. Fingernails, kids' fingernails poking in parents' eyes, foreign bodies. Fluorescein stain is a good way to identify it. So it shows up yellow and brown, or if you put UV light, it sort of shows up a greeny color. If there's a foreign body associated with it, you just need to remove the foreign body, then give chloramphenicol for 5 days, and you might want to put padding on the eye. Right. Endophthalmitis. So this is inflammation of the intraocular fluid, so your vitreous and aqueous humor. Most common cause is post-surgery. So if you get someone in the stem of the question talking about post-surgery and like a acute red eye, think endophthalmitis. You can get it as a result of hematogenous spread. So I think I've seen a case in intensive care due to fungal infection, like a fungalemia. That's not the correct word, but you know what I mean. Severe pain, loss of vision, there may be septic, and then hyperpion. So I've got 2 pictures to illustrate your hyperpion. So you can just see right at the bottom of the eye a hyperpion, and a hazy cornea. So you can see that quite nicely illustrated there. And if you manage to look into the vitreous chamber through the pupil, you'll see sort of infiltrates. So management is you can give intravitreal, so injections into the eye of antimicrobials. You might even need to do a vitrectomy, so remove some of the vitreous. And with that, time for a cup of tea for a good. So okay. So case 4, Seymour, 55-year-old male. He's got pain in the eyes. The pain is worse on eye movement, and is reporting a sudden loss of vision in the right eye. You look at the eye and it's not red. You refer him to ophthalmology urgently. They take a look in there and refer through to neuro. MRI, got sclerotic plaques with Dawson's fingers. Decide to do an LP and find oligoclonal banding. No prizes for guessing what it is. Any ideas?
MS?
Yeah, well, optic neuritis specifically, but yeah, MS. Well, optic neuritis being the presentation, but yeah, they've got MS. So differential for a sudden loss of vision, which is painful. The good thing is you'll notice that we have covered pretty much all of the with red eye differentials. So just be aware that a lot of them can cause a sudden loss of vision. And then without a red eye is optic neuritis, is the main differential that you need to worry about. But yeah, I'm not going to cover the neuro-ophthalmology because you will have done it to death as part of your neurology. But just remember, there's quite a nice crossover at points. Okay, so next one, B.G. Murphy, 60-year-old male. You'll have noticed the theme with the names potentially. Woke up with a loss of vision in the right eye, no pain. On examination, he's got a relative afferent pupillary defect, so you shine light in the affected eye and there's no constriction, but he still has consensual constriction. Visual acuity is in that eye is hand movement only, and then fundoscopies revealing pale retina with cherry red spots. Anyone got any idea? Cool. Sarah's put retinal artery occlusion. That is the correct answer. What other differentials could it be? Cool. So we'll go to differential. So don't get put off, but basically monocular visual loss that's really transient is generally a neuro cause. So migraine, I'm not going to try and pronounce that. I used to be able to. Persistent monocular visual loss that's painless. As Sarah said, central retinal artery occlusion, central retinal vein occlusion, retinal detachment, which I think you got in your formative, or hemorrhage or vitreous hemorrhage. Binocular, again, neuro causes here. So let's go through all of those pathologies, but before we do that, let's just go remind ourselves what a fundus looks like. This is probably quite familiar. So fovea is where the most sort of tight packing of your rods and cones exist. Then you've got your macula, which again, your central vision, really high concentration of rods and cones, and then moving out from there, you have all of your peripheral vision, and then they all lead to where the optic nerve is. So you've got your optic cup and your optic disc. Now, it's worth knowing about this when you look into chronic glaucoma, because what you'll find is that the optic nerve compression that you get as a result of the raised intraocular pressure will increase the size of the optic cup relative to the optic disc, and that's called cupping of the optic disc. So it's worth knowing about because it's a sign of glaucoma. You'll also notice there's loads of patchy bits around here, and you lose your peripheral vision in glaucoma first. So central retinal artery occlusion, it's blockage of the central retinal artery, which is a branch of the ophthalmic, which is a branch of the internal carotid. It's typically an atherosclerotic plaque rupture, but it can also be due to giant cell arteritis. So the risk factors, your normal risk factors for atherosclerotic lesions, so your hypertension, your hyperlipidemias, etc., and then your risk factors for GCA, stuff like polymyalgia rheumatica, age, being female. So clinical presentation, sudden painless loss of vision and a relative afferent pupillary defect. And then you will end up with a fundus that is pale and with a cherry red spot. So I'll show you what that looks like in just a second. Diagnosis is fundoscopy. You'll also need to do an ESR CRP to rule out giant cell arteritis. And if you're a GP and you're worried about giant cell, then you need to give them 80 milligrams of pred to start them with and refer them to ophthalmology ASAP. So here's a retinal artery occlusion. So I could probably convince you that that is pale. And then in the middle, so where the fovea and the macula are, that is where you will find the cherry red spot. And that's literally just because that's the thinnest part of the retina. And so you can often, if you're not getting blood, you can see the choroid and all the underlying tissue, and that's red, and so you get a cherry red spot. So central retinal vein occlusion. So it's a thrombus in the retinal vein, and there's two types. There's central retinal vein occlusion, or there's a branch retinal vein occlusion. So the vein splits into four, and it depends where the thrombus is as to what you see. The risk factors: hypertension, hyperlipidemia, diabetes, smoking, and then SLE and glaucoma. So the SLE obviously predisposing you to clots. So you get a sudden painless loss of vision and a relative afferent pupillary defect. So fundoscopy. So if you think about it, your vein's blocked. So the blood flow is going to be, blood flow out of the retina is going to be impaired. So you get a backing up of the blood, and then you sort of rupture vessels and you get a blot and hemorrhage appearance. You will also get optic disc and macular edema. I can't really spot these very well, but you'll see on the fundoscopy that it's quite easy to spot. So yeah, which one's a branch, which one's a central retinal vein occlusion? I'm asking you this so I can have a slurp of my cup of tea.
The left eye is the branch.
So which one?
So
this
that
one?
Yeah, that one's the branch.
Yep, good. And this one is the central, which you can, yeah, it sort of makes sense, doesn't it? You can see the other veins leading in, and then you can see this vein and the blot, the flame and blot hemorrhage. So we, I think, got a branch vein retinal occlusion in one of the papers that we sat. So it's worth knowing about. Don't worry too much about the treatments. I don't think they're going to necessarily ask you about it, and certainly for the central retinal artery occlusion, the treatments are, there's not a huge amount of evidence behind them, so you try stuff like orbital massage. Retinal detachment. So this is when the retina separates from the choroid and therefore its blood supply. So what you tend to find is it's precipitated by a retinal tear. So if you get a tear, then the vitreous humor can go underneath and start peeling the retina away from the choroid. Risk factors also include posterior vitreous detachment. So we'll talk about that in a second. Diabetic retinopathy and trauma. So you tend to lose your peripheral vision. If you think about the fovea, that's here. And then, you tend to get like a curtain come across vision. That's what you tend to see in your exam stems, and you get flashes and floaters as well as that's happening. So the way you diagnose it, you will do a slit lamp examination. You'll also do something called an OCT, which is basically a scan of the thickness of the retina. It's very good for visualizing a lot of retinal problems. And you can see one of the things that you'll often see in an OCT is the dip where the fovea is, because as I was saying, the fovea is often the thinnest part of the retina. So you need to, when these happen, the treatment, you often need to fix the tear. So you will sometimes use either cryotherapy or a laser. Lasers are a common theme in ophthalmology, and you basically will create adhesions between the choroid and the retina to try and stop it peeling. And then you'll need to do a surgical reattachment of the retina sometimes. So these require an urgent referral to ophthalmology. Okay, posterior vitreous detachment. This rarely causes loss of vision, but can cause complications that do result in visual loss. So the vitreous humor, we've talked about. The outermost layer of the vitreous humor is called the vitreous cortex, and it's a sort of a thicker part of the vitreous, and it adheres to the retina. So it's most strongly adhered in the anterior part, so here and here. But as you get older, the bond between the retina and the vitreous humor, the vitreous cortex gets weaker and weaker, and it's pretty much physiological. As you age, your posterior vitreous cortex will slowly start detaching from your retina. And this starts from about the age of 20 onwards. So I wouldn't be surprised if a couple of you are just starting to. The problem is that once it starts doing that, sometimes it can slightly tear the retina as it's detaching. But most people it doesn't. You can get about 50% of it is an asymptomatic presentation. But for some people, you'll get some flashes and floaters, but it's absolutely fine. Your eye gets used to the change. And then management-wise, you really don't need to do anything unless there's a retinal injury. Sorry, but that's all we need to talk about there. And then a vitreous hemorrhage. You'll be pleased to know this is the penultimate slide for a quiz. So it's literally blood in the vitreous cavity, and there are two causes. So you can get trauma causing tearing of blood vessels and that leaking in, or you can get pathological blood vessels within the vitreous cavity. So you tend not to get blood vessels within the vitreous itself. However, in certain conditions, so diabetic retinopathy, so we're not going through diabetic retinopathy today, but basically you get ischemic injury in parts of the diabetic retina, and then you get the release of vascular endothelial growth factor, and that causes neovascularization, so new blood vessel formation. When these new blood vessels form, they're really friable and prone to bleeding. And so this neovascularization can sort of permeate into the vitreous cavity. And as I said, they're very friable, so they can just sort of pop and you can get some bleeding. Retinal vein occlusion, obviously there's ischemic injury going on there, and you can get neovascularization occurring as well due to VEGF. So clinical presentation, you can either get a floater, so in small vitreous hemorrhages, not all of them, the vision is occluded, so you just sort of get this floating blob. Whereas in big vitreous hemorrhages, you tend to get a complete sudden loss of vision. Diagnosis, if you look at it under a slit lamp, you'll see sort of like a clump of blood. The management is fairly easy, it's self-resolving most of the time, but you might need to do a vitrectomy. So just remove some of the vitreous, and but apart from that, that is all I wanted to talk about today. So we've gone through swelling of the eyelid, we've gone through red eye, painless and painful, and then we've gone through sudden loss of vision. Any questions before we start a quiz? And I hope I haven't gone through it too quickly. So this is only about 9 questions long. We're well ahead of schedule, which happy days. So if there's no questions, we'll start with the quiz. Okay, what's the management of this condition? You can either drop a message or unmute yourself. So first of all, anyone know what the condition is? Feeling alone? Any idea? Any at all?
Is it subconjunctival hemorrhage?
It is indeed. Well done. Yeah. So this is quite a nasty example. This is Wikipedia's photo for it. How would you manage it?
Is it conservative or?
Yeah, it's generally a self-resolving problem. So it looks really nasty, but as long as you're happy there's no underlying problem, then leave it be. Thank you very much. So what is this condition?
Is that anterior uveitis?
It is indeed. So what makes you say that it's anterior uveitis?
The distorted pupil and the hypopyon, I think it's called.
Yep, and there's one other symptom. So yep, there's a hypopyon there, and there's an abnormal. Yeah, sorry.
Oh, no, I was just going to say the ciliary flush is at the last one.
Yeah, fantastic. And you can see that here. Brilliant. So any other, this is a really obscure and a bit personal to me. What else could it be if there wasn't like a hyperion? If they, so I would be impressed if you can get it. It's basically, you can get a collarbone. It could be a collarboma with conjunctivitis. So I've got a collarboma, which means that my pupil's actually irregularly shaped. Just it's an embryological remnant, not remnant, but it's embryological in origins. And I suppose you could have conjunctivitis alongside that, and that would probably give you a fairly similar presentation, albeit without the hyperpion. At least I hope I've not got one of those. But yeah, brilliant. Thank you very much. Okay, what's the management for this? It's a pretty gammy photo, isn't it?
Conjunctivitis.
It is. What type?
Is it viral because it looks clear?
It looks quite mucousy, so clear is really quite thin. So this is actually bacterial. But yeah, the management actually would be fairly similar. So how would you manage it?
Isn't it usually self-resolving? You give them that delayed prescription of chloramphenicol.
Yeah, and then what sort of advice would you give them?
Don't share towels. Don't use contacts.
Yeah, and clean the eye as well. So that's brilliant. This is the one that they love to ask about, is your conjunctivitis. You're being turned into GPs. Okay, a person comes in with sudden loss of vision in one eye. What's the differential? You can either say it or put it in the chat, whatever's more comfortable for you. Okay. Yep, sudden loss of vision could be. If I said it was persistent sudden loss of vision, what could it be?
Retinal artery occlusion.
Yep, or
Vein.
vein, or anyone got anything else? Could be a vitreous hemorrhage as well. Yep, posterior vitreous. So yeah, and I suppose it could be a big retinal detachment as well. So this is their fundus. What have they got?
Is that a central vein occlusion?
Brilliant. Yep. Ace. Okay, what two diagnoses should you not miss if a patient's eyes are swollen? Orbital cellulitis, fantastic, Sarah.
Anaphylaxis?
Yeah, fantastic. Don't miss anaphylaxis. Okay, what's this? Ignore the arrows. I've not shown this photo to you, so I'm being a bit mean.
Is it a vitreous hemorrhage?
Not quite. It's actually a retinal detachment. It's very mean of me because I've not sort of shown you this, but I've shown it to you now, so sorry about that. Okay, what is the clinical presentation of acute angle closure glaucoma? Oh, Habas has said retinal detachment in the comments, so well done. Yeah.
Severe pain?
Yep. So what will the pain often be associated with?
And be worse with light?
Yep, fantastic. What else?
Nausea and vomiting?
Yeah, nausea, vomiting, headache. Yep, and what will they notice around lights?
Halos around lights?
Yeah, fantastic. And they'll have a hazy vision. So if you examined them, what would you find?
Hazy cornea.
Yep, fantastic.
Decreased acuity.
Yes, very much so.
Dilated pupil.
Yep, fantastic. Wonderful. And yeah, and then you did tonometry, and you'd find that that's pretty stonking. Okay, following on, management. Pilocarpine, fantastic. Anything else that we could? What ruins the taste of beer and fizzy drinks? Helps you get used to altitude though.
Acetazolamide.
Yeah, acetazolamide or Diamox if you want to use the brand name. So yeah, and then you can use beta blockers and other carbonic anhydrase inhibitors as well. And then so when you do chronic glaucoma, you wouldn't tend to use it in acute glaucoma, but you can give a drug, prostaglandin, so like latanoprost, and it has a weird side effect of making your eyelashes longer. So it's a weird side effect. Okay, so that's what's pretty much done. Some useful resources. So 0 to Finals has some really nice ophthalmology notes that's really to the point. iWiki is worth having a look at. It's quite in depth. You certainly don't need that level of detail. And then Amboss, if you've not come across Amboss, you've been missing out. You can literally just type in any condition into, it doesn't have to be ophthalmology exclusives, and then type in Amboss afterwards into Google, and then it will give you some really good notes on it. And then Tim Root Opthabook is also really handy. Yeah, a lot of it's paid for, but you can actually read the book itself online for free on his website. Any questions at all?